Okay, welcome to the ARO seminar series centered around the topic of middle ear. Today, we are delighted to have Dr. Gabrielle Merchant as our speaker. My name is Stephen Neely, and I will be your moderator for today's webinar. Before starting today, if you have questions during the presentation, please use the chat function directed at me to type questions to avoid interrupting the presenter. Following the presentation, feel free to unmute and directly ask your question. You can use the raise hand function to be recognized for questions. Any question not addressed during the session will be answered by the presenter in a follow-up email. Closed captioning for this meeting is available for your use, and this session is being recorded and will be made available for later viewing. As a bit of background information about Dr. Gabrielle Merchant, Gabby is an audiologist and hearing scientist and the director of the Translational Auditory Physiology and Perception Laboratory at the Boys Town National Research Hospital. She earned her Bachelor of Arts degree from Smith College, a PhD from the Harvard MIT Speech and Hearing Bioscience and Technology program. And following her PhD, she earned an AUD degree from the University of Massachusetts in Amherst. Her translational hearing research focuses on auditory mechanics, auditory perception, and advancing evidence-based practice through improved clinical diagnostic tools. Her laboratory has a particular focus on children with otitis media, conductive hearing loss, and wideband acoustic emittance. I've had the pleasure of collaborating with Dr. Merchant on her research since she was a graduate student. And we now have a 5-year plan to continue that research into the future. And now, without further ado, it's my pleasure to welcome Dr. Merchant, whose presentation is titled Improving the Diagnosis and Conductive Hearing Loss in Children with Otitis Media.
Thank you so much for that nice introduction, Steve. And thank you to the organizers of this seminar series for inviting me and giving me this opportunity to present some work from our laboratory over the last 6 or 7 years or so on improving the diagnosis of conductive hearing loss in children with otitis media. And it's really special to me actually that Steve is moderating this, because as he mentioned, we have been collaborating on research since I was a PhD student, but I met Steve for the first time at an ARO poster session, I think my second year of my PhD program. So it's fun doing this ARO seminar series and having him moderate it. So I just want to start off with some acknowledgements before we dig into some data. Just take a second to thank the people and the funding that have contributed to and made this work possible. And I want to highlight a few people in particular. So these are all people kind of past and present from my laboratory that have contributed to the work I'm going to talk about today. And I want to highlight Sarah Alsleem here. She's a research audiologist who's been with me since I opened the lab in 2018. She manages the lab. I could not do any of this without her. She's been a huge part of this work. And then also Rick Tempero, who is a surgeon scientist here at Boys Town, who's in a primarily clinical role, but who's collaborated with me on this work since 2017 and influenced so many pieces of it scientifically. We do a ton of recruitment through his clinic, and we could not do this work without him. A few other research audiologists who work in the lab, who are wonderful, and many research assistants past and present. And I also want to highlight collaborators on this work. So Steve, as he mentioned, has been collaborating with me since my PhD, and certainly on this work since I started doing it at Boys Town. Emily Buss at UNC has been a wonderful mentor and collaborator on this work, and Jeff Cruckley, who's helped with a number of the statistical analyses. He's in Canada, as well as kind of former mentors who have influenced every piece of this and who I've kept in very close touch with over the years, many of whom are in this room. Susan Voss, Heidi Nakajima, John Rosowski, the late sawmill merchant, and then Rich Fryman and Karen Helfer, who were mentors of mine at UMass Amherst, and generous support from NIDCD and NIGMS through a number of grants, including the new R01 we just got on this work that Steve mentioned. Okay, so let's dig into some data. So typically, when I begin talking about this work, I start by discussing a clinical encounter that motivated it, and I will get to that. But given the audience today, I wanted to tell kind of the whole story. And so this really started during my PhD when I was at EPL, and I read a wonderful paper by Mike Ravitz and John Rosowski and Sawmill that looked at mechanisms of hearing loss resulting from middle ear fluid in cadaveric preparations. And after reading that, I wondered how we might translate some of what they studied there and some of kind of the questions they were asking into human studies. And so that's kind of always been a big interest of mine, is taking these, studies in animal models and cadaveric preparations where things are really homogeneous and well controlled, and translating them to similar studies or conditions in humans where things are often a bit more messy, while still trying to maintain as much control as possible. And in fact, I got so interested in this that I convinced Heidi to let me do a kind of a little side project where we started to try to dig into this in kids with fluid getting tubes placed in the OR. And we were able to collect some data. That's the kind of Excel spreadsheet summary of some of what we collected while I was there. And long story short, it didn't kind of turn into a full project because we realized that the bandwidth that it would take for me to really study this well and comprehensively was more than I really had to give for a side project. I had kind of a main dissertation project I was already working on. And so I had to table that at the time, but it kind of stuck with me. And so fast forward to during my AUD, which I did after my PhD, I was working as a student clinician on a pediatric ENT clinic one afternoon, and I saw 3 kids back to back that really brought me back to thinking about some of those questions I had thought about a bit during my PhD. So the first child came in and had grossly normal otoscopy, nothing kind of hugely abnormal that we observed, but a flat tympanogram, which is a kind of a simple measure of middle ear mobility. So that's usually suggestive of middle ear dysfunction in kids, most often fluid. And then we were able to get some good behavioral data on this child using a behavioral audiometry. And what we found was a pretty moderate conductive hearing loss. So that fluid was causing some hearing loss in that ear. And then the next child came in, had a very similar presentation. This child was a little bit younger, grossly normal otoscopy, flat tympanogram, but the thresholds that we were able to get, we didn't get as much behavioral audiometric information. That child was younger, didn't condition to bone conduction. We could only get some air conduction, but thresholds were in kind of a near normal hearing range. So the question kind of came to my mind at that point is, why did the first child have hearing loss, but the second child, who's largely presenting the same, doesn't? And then a third kiddo, a 20-month-old, came in right after those first 2, same presentation, grossly normal otoscopy, flat tympanogram, and they would not condition to behavioral audiometry, which is pretty common in this age range. So we have no idea really how they're hearing. So the question then is, how is this child hearing? Do they have hearing loss? Do they not? And does it matter if they have hearing loss or not? And so the research I was doing at UMass at the time, excuse me, with Rich Fryman and Karen Helfer, was thinking a lot about speech perception and binaural hearing. And so I decided after seeing those patients to dig into the literature a bit to look at, what are the implications of hearing loss from OM? And if you have hearing loss or if you don't have hearing loss, are there downstream effects? I found a lot of interesting papers in the literature, some that suggested there are long-term behavioral consequences of otitis media, and others that suggested that basically once the OM and the hearing loss resolves, we don't really have anything to worry about. But 2 particularly impactful papers for me were, one, this review paper, beautiful review paper by John Witten and Dan Pauly, looking at the consequences of auditory deprivation in early life, kind of comparing basic animal studies that really suggest that there's probably some things we have to be concerned about if you have kind of auditory deprivation, particularly during critical developmental periods, in contrast to some of the clinical studies, which were showing kind of more equivocal outcomes. And some work from UNC, from Joe Hall and John Gross and Harold Pillsbury, who were interested in the effect of otitis media on binaural hearing. And they measured this binaural hearing metric called the masking level difference. And kind of in this gray area would be poorer binaural hearing. And these triangles are kids with otitis media kind of before surgery. So they all have poorer binaural hearing outcomes. But then at 3 months, and then kind of intervals up to 4 years after kind of the OM has resolved. And even at 4 years, even though on a group level the effect is gone, there are still children with persistent deficits in binaural hearing. And so I wonder, is there something about those kids that are kind of having these persistent deficits that kind of put them at higher risk? Can we learn about who those kids are? So that leads me kind of to the problems and questions that my research program is seeking to answer. And so really at the core of this is that otitis media has many forms and there's tons of variability in it. So whether effusion is present or absent, how much effusion or fluid is present if it's there, what the viscosity of that fluid is, whether there's infection and inflammation present, if there's hearing loss, and if so, what's the magnitude of that hearing loss, the symmetry or asymmetry of it, the duration. And we really kind of, with our current diagnostic tools, have limited knowledge of kind of how these variables are related and how they impact a given episode and or long-term outcomes. So do effusion characteristics impact hearing loss? Do they impact the prognosis or kind of spontaneous resolution of OM? And what variables might be important to consider for management that we don't currently consider, and how do we identify and measure them? And then kind of long-term, how does all this variability influence whether there are long-term behavioral or otherwise consequences of otitis media? So that's a lot of words. So I'm going to try and outline some of these questions in a slightly different way. So though that clinical data is somewhat equivocal, we know that otitis media can lead to long-term behavioral consequences, such as deficits in speech, language, auditory processing, binaural hearing, hearing and noise, spatial hearing, academic struggles, and increased listening effort. But we also know that this doesn't happen for all children. So there's clearly some mediating variables. And given how heterogeneous otitis media is, that isn't surprising. So what are these possible mediating variables? They include things like otitis media volume, viscosity, presence of infection, whether it's bacterial or viral, whether it presents unilaterally or bilaterally, whether the hearing loss is present or absent, whether it's unilateral, bilateral, whether kind of what the magnitude of that hearing loss is, and whether it's symmetric or asymmetric. And then, my clicker, prognosis. So whether kind of episode of OM is persistent or it resolves spontaneously, how long it persists for, and if it's stable during that period, and if it's fluctuating. So not only are these variables potentially influencing kind of these long-term behavioral outcomes, they could also be influencing each other. So OM variables might be influencing hearing loss variables and prognosis, for example, et cetera. And we don't really know how all of these things are interacting. And truthfully, there's probably a lot more arrows that this diagram needs. But my goal of my research program has really been to try to kind of start to pull apart some of these relationships more clearly and figure out what the important ones are. And so while there are a lot of variables at play here, one of my main hypotheses of this work is that all of these variables in some way interact to influence the presence or absence of some amount of auditory deprivation, at least for kind of the types of behavioral outcomes that I'm interested in. And I hypothesize that it's really this cumulative auditory deprivation that's driving deficits kind of long-term. And I'm sure that there's other patient variables kind of not considered here directly related to OM, like age of the child and age at which the insult occurs, SES, and maternal education that are also factoring in. So a lot of things to consider. So my short-term research plan is to really understand kind of this top part of this figure, how all of these variables might influence each other and in turn influence cumulative auditory deprivation, with a long-term goal of determining what factors put children at risk for long-term deficits, and then to develop ways to identify them in clinic as early as possible to better inform management decisions. So my research program uses a number of different approaches to study these questions. This is sort of just a visual sampling of them, many of which I'll talk about today. So we use a number of standard clinical audiologic measures like behavioral audiometry. So you think of that when you hear the beep and you raise your hand. We get a little more creative with pediatrics and we have to kind of make it play-based. Tympanograms, a more kind of comprehensive advanced assessment of auditory mechanics called wideband acoustic emittance, which I'll talk about. Acoustic reflexes, otoacoustic emissions, the auditory brainstem response. We do computational modeling, largely in conjunction and collaboration with Steve Neely, and looking at kind of different diagnostic tests and what their sensitivity and specificity are. And this is kind of a app we use to test binaural hearing, both the masking level difference and the binaural intelligibility level difference. Okay, so for the data I'm going to talk about today, the participants are children with otitis media, primarily otitis media with effusion. We recruit largely from our ENT clinics, and so it's this more persistent state of fluid where there's often not a lot of infection or active kind of infection and inflammation present. And these are children who were scheduled to have tubes placed and confirmed to have fluid at the time of kind of enrollment in the study. We enroll anyone basically 6 months and older. And that skews, however, kind of to really younger kids because of the incidence of OM. So the mean age of the kids in the studies that you're going to hear about today are about 34 months of age. And these children participate in a large battery of assessments within the 48 hours prior to their tube surgery. So, if they have surgery on a Wednesday at 7 a.m., we try to bring them in Tuesday at some point, and really Tuesday afternoon if we can, but there were some kids that we couldn't bring in on Tuesday, so they came in on Monday. So these children were all seen within 48 hours of tube placement. And then I always see them the morning of surgery and pre-op before they go back to confirm that there hasn't been a significant change in their middle ear status. So I repeat tympanometry and wideband acoustic admittance that morning and make sure it kind of matches up with what we saw in the lab for those measurements so that we can say that what we kind of observed in the lab should correlate nicely with how they are presenting on the day of surgery. We also have a population of age-matched normal hearing control children who have no recent history of OM for the last 12 months. And in all the kids I'm going to talk about today, sensorineural hearing loss has been ruled out, which means that we're only looking at conductive hearing loss. So this is just kind of a visual of the protocol. So they have the initial visit in the lab. And what we do there is we do a measurement called wideband acoustic admittance and standard tympanometry. I'll talk a little bit more about wideband in a minute. We do otoacoustic emissions, and then we do behavioral audiometry, ideally ear-specific air and bone. I will talk later about how we do not always get that in everyone, but we attempt it in absolutely everyone. On the day of surgery, we do wideband and TIMPs in the pre-op room to confirm there's no change. And then we do a few things in the OR. And so for these studies, we were doing TIMPs pre and post myringotomy that was trying to get an assessment, kind of an objective way to look at volume kind of compared to kind of an absolute volume. We have actually found that that's not super informative, but that's what we were doing. And then we also try to subjectively describe the effusion characteristics. So is the effusion full, partial? Is the ear now clear and does not have fluid? And then we collect the fluid and try to quantify the volume, viscosity, and purulence. And I will talk about that as well. And then we bring all the kids back for a post-op visit about 1 month after they've had surgery and repeat all of the testing. So most of the measures that I'm going to talk about are kind of standard clinical audiologic assessments, and I'm going to assume in this group some level of knowledge about those. But the one thing that's not kind of done to standard clinically that we do is wideband acoustic admittance. So this isn't a new tool. It's been around for over 20 years now, probably 30. But it still is kind of slowly making its way into clinic. And so unlike standard tympanometry, which we typically do in response to kind of a single frequency pure tone, wideband acoustic admittance is looking at kind of the transmission of sound through the periphery in response to a wideband stimulus. So typically clicks or chirps from around 200 hertz to around 8,000 hertz. It's FDA approved, and there's lots of different outcome metrics that you can look at for wideband acoustic admittance. It's a complex response. So you can look at magnitude and phase, but the most common kind of transformation that we look at in the literature is called the absorbance, and that's the portion of energy being absorbed by the ear. So we know what we've kind of applied with a sound stimulus, and we're looking at how much is reflected back, and then in turn, we can assume how much was absorbed by the middle ear system. For quantification of effusion volume and velocity, we would collect a sample of effusion using this kind of suction device here. So it's called a TIMP tap, and it connects to the suction, and you can actually collect a little of the effusion. It drops into this cavity, and then we can pull that up into a micropipette and put it through this microviscometer, and it basically pushes a small sample of effusion through a microfluidic channel, and the device will spit out a dynamic viscosity and centipoise, and also measures volume very precisely on the order of microliters. That said, we haven't found much success with this either, unfortunately. I think part of the problem is that these effusions are not homogeneous in their viscosity. And so they, there's parts of them that are highly viscous, and there's kind of some parts of them that have a lower viscosity. So as you push it through, it's trying to get a reliable viscosity, and it's like high viscosity, less viscosity, higher viscosity. And so we didn't find that the measurements showed high reliability. And so we've kind of moved away from quantifying it in this way and instead quantifying it more qualitatively as mucoid serous or purulent. So The way we've kind of quantified the effusion characteristics so far is kind of volume based on the otolaryngologist or operating surgeon, which primarily has been Dr. Tempero, looking in very carefully and saying, I see no evidence of air. This is a completely full effusion, or noticing an air bubble or an air fluid line or some evidence of air, which would classify it as a partial effusion. And that partial effusion could be anywhere from like 95% full to 5% full, or that there's really no measurable fluid present at the time of surgery. So those are clear ears. And so of our kiddos in kind of this initial population of data, you're going to see they were all diagnosed with OME in clinic, and then somewhere between 5 and 57 days later, sometimes it takes a really long time to get them into surgery, they were seen in the lab. And 61% of them did have effusion at the time of tube placement. So 39% were clear ears. And of the 61% that had fluid still, 39% were partial effusions and 61% were completely full. And the vast majority were determined to be mucoid effusion. So only a few were serous and one was considered to be purulent. So there wasn't really much variability in viscosity that we could look at. So we really decided to kind of focus on the effect of volume, since we had some variability there between the clear ears, the partial ears, and the few full ears. All right, so the first outcome we're going to look at is behavioral audiometry. And we know from previous work that kind of hearing outcomes related to OM can be highly variable, from no hearing loss to 40-50 dB hearing losses. And so when we look at kind of the hearing losses we see in our children, we see the same thing. There were ears that were kind of presented with pretty normal threshold near 20 dB HL, and ears that had 40 to 50 dB thresholds. But when we separate the groups out by kind of how much fluid or effusion volume, we find a very kind of consistent effect where ears that are completely full of fluid are those ears that tend to have those 40 plus dB moderate conductive hearing losses, whereas ears that were partially full or clear at the time of tube placement kind of hovered around that normative 20 dB HL line. However, they were statistically poorer than the age-matched normal controls with no history of OM, who kind of had between 0 and 10 dB thresholds. So that isn't to say there isn't, some concern for this kind of slight or mild hearing loss that we see in the clear and partial ears, but certainly it is significantly more impactful, it seems, on auditory transmission to have an ear completely full of fluid. And this is consistent with that paper that I described in the very beginning that Mike Ravitz wrote on those kind of what they found about the effect of effusion volume on sound transmission. The next outcome measure we're going to look at is kind of standard tympanometry. So because we were kind of seeing kids, I think the youngest kiddo in this cohort was 9 months old. We just did 226 Hertz tympanometry on all of them. And this is a measure that we use in clinic super routinely to look at auditory mechanics, but it's generally, it's used at this single frequency, which is really only telling us about kind of the stiffness dominated low frequency response, which has always been interesting to me because we measure hearing across a wide range of frequencies. We look at OAEs across a wide range of frequencies, and yet we consistently look at auditory mechanics and middle ear sound transmission at this low frequency stiffness dominated region. But anyway, what we find is that there is no real difference that we could see at any of the parameters, whether an effusion was full or partial. So you can't really say anything about effusion volume from the tympanometry. So this is just an example case of a child who had a partial effusion in one ear and a full effusion in the other, and his TIMPs were essentially identical. So it did not really seem to differentiate, and that was true for the whole group of kiddos. In contrast, effusion volume does appear to have a systematic effect on distortion product otoacoustic emissions, but somewhat differently than hearing level. So clinically, most people don't do OAEs if there's middle ear dysfunction because they assume it will be absent because that kind of otoacoustic emission gets reduced, kind of the stimulus gets reduced on the way in, and then the OAE itself gets reduced on the way out, and it's kind of a double whammy. But we do find them to be kind of useful in this population. And so what we see is that in contrast to normal responses, so this is just the SNR of the DPOAE level relative to the noise floor, ears that had recent history of OM but were clear of fluid at the time of tube placement still have poorer DPOAEs. And then if you have a partial effusion, it's even poorer. And then if you have a full effusion, usually you have absent DPOEs across the board. And what we actually find is that partial effusions, usually there's like a couple OAEs that pop up just in this kind of mid, 4, 5, 6 kilohertz frequency range. And that's usually indicative to me that it's a partial and not a completely full effusion, which has been really helpful in kind of distinguishing those two. But you see this kind of gradient effect as effusion volume increases that we didn't see with hearing, this difference between clear and partial. And that's likely because there's both forward and reverse kind of transmission effects on the OAEs that aren't true for the behavioral thresholds. So now we're going to look at wideband acoustic emittance, which again is that measure of kind of auditory mechanics, but across a wide frequency range. And so if we look at the individual data here, we see tons of variability. And you might say, well, that's all over the board and not very helpful. But actually, I think that variability is what's helpful and actually could be really telling and useful in clinic, because when we then separate it the groups out by whether by the effusion volume, what we see is a really strong and consistent effect. So the full years have a very consistent pattern of being kind of reduced across the board with a small kind of peak around 4 kilohertz. And then as effusion volume decreases, the absorbance increases. So what you see here is kind of low to high frequencies, and low absorbance means less getting into the middle ear. High absorbance of 1 means everything was absorbed by the middle ear. And this black curve here is a pretty traditional normal. Tracing what we'd see, the clear ears look pretty similar to normal, though a little bit reduced in this mid-frequency range here. Again, the partials are even more reduced and the full ears are completely reduced. So there's this very strong effect of effusion volume on this wideband acoustic emittance measurement that I think kind of highlights why this variability in these measurements can be helpful. And while group level data is always interesting and exciting, as clinicians, we don't measure groups of patients, we measure individual patients. So I'm always really eager to see how things look on an individual level. And so when we dig into the individual data, you can see that qualitatively, those patterns that we see on the group level are pretty consistent with the individual data. So that was exciting. And then we wanted to see the diagnostic potential of this measurement in determining kind of automatically the volume of the effusion. So what we did is we trained a machine learning algorithm to kind of automatically detect whether the effusion was full, partial, clear, or it was a normal control ear. And so we trained the model on 70% of the data and then validated it on 30% of unseen data. And then kind of looked at the sensitivity and specificity for a few different comparisons. So first we looked at effusion present versus absent. So was there fluid or was there not? And it determines that with a very high accuracy, 95%. And that is higher than kind of standard tympanometry can do based on kind of a number of different publications. We then looked at could it distinguish full ears from partial ears, and it does that with, again, a pretty high accuracy, 89%, an area under the curve of 0.944. And then we looked at whether it could distinguish these clear ears from normal ears. And as you can see, they look pretty similar. So it had a bit of a harder time to do that. And so the accuracy is a bit lower, but still moderate. And really clinically, I think I'm more interested in, is there effusion present or absent? And if there's effusion present, is it full or partial because of the kind of difference in hearing loss there? And so these results were very encouraging that we could kind of make those important clinical distinctions. Additionally, however, we're always looking for ways to kind of make these kind of model predictions even more accurately. So in collaboration with Steve, we then modeled these wideband absorbance responses using a computational kind of simple lumped element model. And so we fit the wideband acoustic emittance data to the model. And this model isn't really meant to represent specific kind of anatomy, but more the gross underlying mechanics of the system. And so the parameters kind of collectively represent mechanical aspects that can change due to pathology. And the idea is that we can model kind of the ear canal here separate from the middle ear, and then kind of directly look at, instead of kind of an ear canal impedance, which is what we're measuring with absorbance, a middle ear impedance, which might remove the influence of the ear canal. Now, theoretically, absorbance measurements shouldn't be influenced by the ear canal, but that's based on a theory that the ear canal is a kind of rigid cavity with a consistent cross-sectional area. And we know that's not true in real ears. And so we do think that being able to remove even small ear canal effects might add kind of more diagnostic precision. And long story short, the area under the curve does improve for that clear versus normal distinction using this approach. And actually the area under the curve further improves even when we just look at absorbance for the other kind of comparisons of fusion present or absent and the full versus partial ears. So combining kind of these absorbance or wideband acoustic emits measurements with a computational model does appear to improve diagnostic accuracy. So kind of summarizing this section, unlike standard tympanometry, these wideband acoustic emits absorbance measurements do show significant promise in predicting a fusion volume. So again, here's a child with those identical timps, and here's his wideband tracings. And so even though his timps look the same, his wideband tracings look very different. So on the left here is that partial ear, and you can see how much kind of higher the absorbance is versus the full ear here. This was also kind of an interesting case where I found the wideband really useful over the tympanometry. I probably have hundreds of cases at this point where I feel like the wideband is so much more useful than the tympanometry. But this was a kid I just saw who got diagnosed with AOM, acute otitis media, so that kind of active inflammatory state. I'm at peds, and it's a colleague's child, so she brought him in. And I did a standard timp on him in the right ear first. And I saw, it's not a normal timp, but what appeared to be pretty good mobility. And we repeated this like 3 times. It was very clearly, had kind of a, not a clear peak, but a lot of mobility in it. And then I did OAEs just because the way our protocol runs, and they were completely absent. And I started to get worried. And he was a bit of a late talker. And I was like, oh my goodness, am I going to diagnose my colleague's child right now, some hearing loss? And then as soon as I ran the absorbance measurement, I felt a big sigh of relief because it was very kind of low and consistent with what we see with a full effusion and or acute otitis media, and likely kind of a mild to moderate hearing loss based on what we were seeing. So you don't see kind of the same interpretation of the response and the absorbance as I would take from the tympanometry. And it was very reassuring and consistent with his DPOAEs, which was great because we couldn't get any behavioral data on him. And then in the left ear, you see what is, I think, actually extreme negative pressure, though if we didn't go down to that high end pressure, it might just look pretty flat, but he had beautiful OAEs on that side and much more normal looking absorbance. So we knew that in that left ear, he likely had little to no effusion, just kind of negative pressure, and was hearing probably pretty well. So to summarize kind of what we talked about so far and why these data are exciting to us, we know there's a wide range of hearing loss that OME can cause. And even if you look at like the 2 clinical practice guidelines, knowledge of that hearing loss is important for management, but it's also likely important for thinking about and understanding risk factors for long-term behavioral outcomes. But testing hearing in this age range is really hard. You cannot get this nice behavioral data in a lot of these kids. And so knowing that there's a strong relationship between volume of effusion, hearing loss, and absorbance might allow us to infer how a child is hearing. So if I know they have a full effusion, I can infer that they're probably not hearing very well in comparison to if they have a partial effusion that suggests they're probably hearing better. And this actually came in handy in my own life not too long ago. We actually brought my son Grayson in for a colleague study looking at kind of rotary chair outcomes. And we do admittance testing as part of that protocol, and his timps looked really flat. So we didn't know he had an ear infection. I'm a bad mom audiologist, I guess. But then we ran wideband, and it was clear to me that those were partial effusions and his ears weren't completely full. So he probably was hearing pretty okay, which is probably why I didn't notice there was a problem. And actually in this study, which I collaborated with Kristen Jenke, we found a really high incidence of this incidental middle ear dysfunction, such like with so many cases that we're actually writing a whole separate paper. So the study was supposed to be developing normative data, but it's really hard to find kids with normal middle ear function in this age range, as it turns out. And none of these were kids that we recruited intentionally with OM. They all came in as kind of normal control subjects. And there was a big cohort that presented a lot like Grayson with flat timps. So certainly a prevalent problem. And one more case I wanted to share. It's just that sometimes it's really helpful for the wideband to tell us what's going on, but it's also been helpful even when we have behavioral data when things don't add up to kind of add it to the battery. So this is a child who was older. He was 8 years old, seen in clinic for suspected otitis media. This was his clinical assessment. So flat tympanograms, a bilateral conductive hearing loss. And he goes over to see Dr. Tempero, an ENT. And Dr. Tempero couldn't visualize fluid. Actually, he wrote it on his note, which I thought was really interesting. He said, on otologic exam, I thought the middle ear was aerated. We repeated his tympanogram. So my research audiologist, Sarah, who I mentioned at the beginning, was in clinic that day. And he said, Sarah, can the timp be wrong? And she's like, I mean, and he's like, I'm sending him back. So he sends him back to audiology, repeats the timp, still flat. And he's like, okay, got to be fluid. He's 8. He's got conductive hearing loss, flat tip, must be fluid. And so they discussed kind of the high incidence of, middle ear dysfunction in this age range due to fluid, and scheduled him for BMT or tube placement, and we enrolled him in our study. And so a few weeks later, he comes into the lab prior to his tube placement, actually right the night before. It was a late appointment, and we run our whole protocol on him. And in both ears, the pattern wasn't really consistent with what we see in kids with OM. So TIMPs were still abnormal, but OAEs were present in both ears. Now, you might not say one OAE is significant, but in our pattern, we don't see one OAE pop up usually if there's a full effusion consistent with kind of a notable amount of hearing loss. And what was most notable is that left ear, which had pretty good, still lightly a little bit stiff, but pretty good absorbance, even in the presence of kind of a notable amount of conductive hearing loss. And so that suggested to us that it wasn't fluid. There's likely something else causing that. I suspect some sort of congenital fixation. And so we made the tough call to unblind Dr. Tempero in the morning to these results, because after I read his note, I was like, he knows there's no fluid too, but he just didn't have a tool to kind of confirm what he was seeing visually. And so as soon as he saw the absorbance tracings, he's like, I knew it. And we talked to mom, and mom said that she actually has had several tubes placements. It's never resolved her conductive hearing loss. And now they blame her residual conductive hearing loss on like scarring and things like that. And I'm like, I bet you have a congenital fixation too. So that was just an interesting case. And we've seen this a few times where I think it turned out to be cholesteatoma and not OME. So when kind of this comprehensive profile doesn't add up, the wideband adds a lot to that picture. And so some of my excitement about this sort of rests on this idea that testing hearing in children is hard. And on some of my initial grant submissions, I got pushback on that, and that it really isn't that hard. And we get a lot of audiometric information on these kids, and this isn't really adding anything to the battery. And so we wanted to quantify this. And so while behavioral audiometry is certainly no doubt the gold standard, as great as it is, we really cannot complete it in a large percentage of children in the age range where OM is most common. And so what we did is we quantified this in children less than 5 who were seen in our studies, and looked at their clinical data as well as what we were able to get in a research setting where we have kind of like every resource at our disposal. We always have 2 testers, super experienced pediatric audiologists. We have ample time. We can take breaks. We have like billions of toys. Like we really have every kind of tool in our arsenal. And even still, we don't get this on the vast majority of kids. So in clinic, in these 80 ears that we looked at here, these kids averaged at 23 months of age. We got absolutely no ear-specific information in 73% of kids. And in 15% of ears did we get kind of what would be consistent with a pure tone average, so 4 air conduction thresholds. I don't even put the bone conduction audiometry on here because it would just make you really sad. And in research, we do a little better, but we still get absolutely no ear-specific information on 55% of kids. So we can get sound fields on a lot of these, and that could tell you often if they have access to speech or language, but especially for outcomes like binaural processing and things, kind of ear-specific information and understanding the symmetry of the hearing loss is likely going to be really important. And so a child who has, a big hearing loss in one ear and normal hearing in the other is going to do fine on a sound field assessment. So really getting that ear-specific information is critical. And we do not get that in the vast majority of kids. And this again is at Boys Town. So this is kind of a high level pediatric tertiary clinic where we have a lot of expertise. So I imagine in clinics with less resources, especially pediatric specific expertise and resources, these numbers might look really different too. And in that same population of kiddos, we were successful in getting wideband in 96% of the kids. So it is certainly much easier. And so now we're turning our attention to, we see this relationship between effusion volume and hearing loss, and kind of inferring that, okay, if you see a full effusion on wideband, you can infer that they have a lot of hearing loss. Could we kind of take effusion volume out of the equation, especially since it's kind of in a subjective assessment, and just look at directly estimating conductive hearing loss from wideband? And so my very first pass at this, which I truly thought would not work at all, but I was just kind of curious, was to take that absorbance tracing and average it across the whole frequency range into a single number. And so this number here is what we call average absorbance, and it's across the entire frequency range. I didn't try to go into a specific frequency range. I did not get fancy initially. And again, I really didn't think this was going to work at all. And we compared that with the average air bone gap in that ear. So these are in children where we did have masked bone conduction in their ear and air conduction thresholds. And so we looked at each frequency, so 500, 1,000, 2,000, and 4,000 hertz with that air bone gap, and then we average it across those 4 frequencies. And we see a very, very strong relationship between that average absorbance and that air bone gap, even such that, like, if you look in these full ears here that are purple, even when they're considered full effusions, sometimes the average absorbance is still higher than in other cases. And that seems to have a strong correlation with how much hearing loss they have on average. So our goal is really to develop a wideband acoustic emittance-based acoustic estimate of conductive hearing loss caused by OM within like 3 to 5 dBHL of their actual hearing threshold, which is kind of within test-retest reliability, even when you can get thresholds. And our preliminary data suggests that this is achievable, particularly when combined it with that computational model. So this is a slightly different model. We've added one more parameter since we published that paper. But we're using kind of the same approach, a relatively simple electric analog model of ear canal acoustics and middle ear mechanics to model these individual absorbance data to predict the magnitude of the conductive hearing loss. And I won't go into all of the details. This is recently published, so you can find that there. But when we use this method, when we compare their actual 4-tone pure tone average to our predicted loss based on some of the parameters coming out of this model, we get a mean absolute difference of 3.2 dB. So there's like a really beautiful 0.95 correlation there between the two. And I think this is good, highly suggested that we should be able to develop a nice estimate of conductive hearing loss directly from these wideband measurements and kind of take that variable of effusion volume even completely out of it. And so the last thing I'm going to talk about kind of related to this work specifically is that all of this has been really exciting. We've published several papers on this, and I think, especially when I present this to clinical audiences, they seem really excited about it, but making that step to actually getting this into clinic is kind of, I feel like, a missing piece in a lot of this work. And so like we can give them all the data, but then like having the clinicians take it and actually do something with it has been, I feel like, kind of a gap, especially for wideband. I think that's one of the reasons we're not seeing it used clinically. And so we're trying to start to help bridge that gap. And this is really, really new. Like we are just starting to think about this, kind of what implementation might look like and what we can do on our end to facilitate that. But one thing we're trying to do is to develop kind of machine learning outputs for automatic wideband interpretation so that an audiologist doesn't have to look at the output and say like, oh, I think that looks full, or I think that looks partial, but it kind of spits out some metrics for you. And so this is just an example of what some code that Steve wrote that might kind of give you an idea of what this could look like. We'd make it much prettier, I think, in the end. But the model looks at admittance, magnitude, and phase. So that's why those are plotted there. And then you see the absorbance there. And you can see it at both TPP and 0 decapascals. This is not left and right ears for those of you that think about red and blue to always mean left and right like I do. But in this bottom kind of right-hand corner of each of these panels is the interpretation. And so it tells you here whether it thinks it's full, partial, clear, or normal. And it can do that kind of with a percentage of confidence. So in this first case, it mostly thinks it's normal, but there's a small chance it might be a clear ear with a recent history of OM. And what it actually was normal. And there was no behavioral audiometric information on this child, but it would estimate that the behavioral audiometry would give you an average conductive hearing loss of 5 dB. In contrast to this ear over here, which it estimates to be a partial effusion, you can see how lower the absorbance is, and it estimates the hearing loss to be 25. Again, no behavioral information. These last 3 examples do have some behavioral data. So it estimates it to be a partial. It was confirmed in surgery to be a partial. It estimates the conductive hearing loss at 21, whereas the actual PTA was 24. It estimates, in this case, the PTA to be 12, but it was actually 11. Again, it agreed 100% that it was a partial. And this is a full ear that was confirmed in surgery to be full. It estimated the hearing loss to be 47 dBHL, and the actual PTA was 44. So that's something that we could implement, would spit out partial, full, clear, normal, and or how much we estimate the conductive hearing loss to be. And I think that would really improve clinicians' desire to utilize this because we're giving them kind of the automated information. Another thing that we're trying to do is to create some kind of smart phrases, if you will, or things that can be easily used by clinicians to report on these findings. So that's been another barrier I've found in talking to clinicians, is that, you know, they don't really know what to say in their report. So these are just some examples, and I won't read them out loud, but to kind of give you an idea that we are thinking about this and working on it and trying to provide some guidance for clinicians on what they could say in their reporting that could describe these outcomes. So that kind of summarizes what we've done largely up until about 9 months ago, and it's still much of that is ongoing, kind of that single visit information. But the last thing I wanted to touch on with a little bit of what time is remaining is some very recent work that we've started doing on monitoring OME and conductive hearing loss using mobile testing. So improving our understanding and knowledge of what's happening with a given episode at one time point is helpful, but that's probably not going to tell us much about long-term outcomes or cumulative auditory deprivation, because you need some sort of longitudinal data for that. And so we, about 9 months ago, got some funding to start monitoring kids using a mobile testing van. And the goal of our mobile OM project is really to understand the trajectory of otitis media episodes and also the prognostic value of wideband in that. So when we see them initially, can we predict with wideband or really any other outcome metric that we're looking at how that kind of trajectory of OME is going to progress? Is it going to persist? Is it going to clear on its own? You know, is the hearing loss going to be stable? Is it going to fluctuate? Things like that. And so for all of these kiddos, we have an initial kind of comprehensive battery, otoscopy, standard tympanometry, wideband acoustic admittance, OAEs, and a comprehensive hearing assessment, behavioral pure tone audiometry. And then we monitor them weekly with the van, where we repeat otoscopy, tympanometry, wideband acoustic admittance, and DPOAEs. And if we think there's been a change in middle ear status based on any of those assessments, we also repeat the audiogram. And we can do that in the van for many kids. We can't do VRA in the van. So kids who are younger than about 2, we have to bring them back into the lab if we want to repeat their hearing test. And these are just some pictures. So this is our van, this is our wagon, and how we transport equipment. This van is one that was previously used by an investigator for language testing. So it's not set up ideally for the testing we're doing, but we're making it work. And with my R01 that just got funded, we are in the process of designing a van that will be really even better suited for our needs in our testing. And so that's in progress as well. But even despite the limitations of the van, we've been really successful in doing CPA, wideband, OAEs, in the van. I think the noise floors are kind of shocking to me how good they can get in the van. So we've been pretty fortunate. And I just want to show you, again, this is really early data, but a few kind of examples of the kind of data we can get with this protocol. And so this is a control participant. And so you see tympanograms here, audiometry, wideband acoustic admittance, and otoacoustic emissions. And so this is a kiddo, one of our normal controls. So you see nice normal tympanograms. We only got behavioral threshold in one ear. And I'm sorry, my son is homesick today. And so he's saying, hi, Bubby, I'm on a call, okay? Okay. And we see normal wideband acoustic admittance in both ears and nice OAEs. And if we monitor them, so this is week 2 and week 4, you see that persist. So we can see that stable middle ear status over time. This is a kiddo who is enrolled as part of the OME cohort. So you can see in that right ear, a flat tympanogram, the left ear, negative pressure. You see the left ear's hearing pretty normally, some kind of increased thresholds of low frequencies, likely due to that negative pressure. The right ear has more hearing loss and lower absorbance and no otoacoustic emissions present. So this is probably a full effusion and a largely normal ear with some negative pressure on the left side. It also kind of highlights how different the ears can be with OME. I think a lot of people assume that what's happening in one ear is likely happening in the other, and that's just not the case in a lot of cases. We went back and monitored them a week later, and what's interesting here is that you see that right ear actually improves a bit, so the absorbance increases, the hearing gets a little bit better, and the OAE start to pop up. So still on a normal hearing ear, but improved. And then we go back on a week later, and we see the absorbance decreases. So not as bad as it was to begin with, but we do see the hearing has reduced a bit and the absorbance has reduced a bit. And what's interesting is that you don't see the TIMP really changing at all, even though you see the wideband very clearly changing across the board. And then this is just a third case, another OME child. And so who has kind of more symmetric hearing. So flat TIMPs, partial effusions as evidenced by kind of both the wideband tracing and the partial otoacoustic emissions. Week 2, we went back and very flat temps. Actually, I thought this was interesting because the temps are actually poorest, if you will, at week 2, but this is where they're hearing the best. Most likely, you can see the OAEs are the best at this time point, and the absorbance is highest at this time point. And then week 5, we went back, so it kind of stabilized like this for several weeks. And then at week 5, we went back, still flat temps. The absorbance really reduced across the board, and now the OAEs were completely gone. And this child actually got acute otitis media like the night before she was going to get surgery. And that's what is presenting here. And so we're still trying to figure out how to kind of show these data and analyze these data in a nice way. But each of these lines, this is one way we've done it. Each of these lines is an ear of a participant. And you see our OM group on the top and our controls on the bottom. And the darker you see means basically better hearing, better sound transmission. And so in our OM ears, you see lighter kind of colors here for tympanometry status versus the controls. The majority of our controls have type A temps. Though again, we find a lot of incidental middle ear dysfunction in this population, and sometimes it's very persistent. We've actually had kids move groups before. And then in our OM group, you see mostly type B temps, so there's a little bit of variability there. If we look instead of tympanometry at a fusion volume, which gives us, we think, a little finer grain information, you see even when there's abnormal tympanometry in some cases, we still think that ear is clear of fluid and probably hearing very well. And so we see basically a little more fine grain detail in a fusion volume, but still kind of a lot of it is grossly abnormal in the OME group. And then if we look at OAEs and wideband absorbance, and here we're just using average absorbance, we see kind of the most distinction. And so we can see really subtle changes in wideband average absorbance that likely correlates with OAEs. And so where we see again lighter here is poorer hearing, fewer OAEs, lower absorbance. And across the board, you see obviously the OM group has poorer OAEs and lower absorbance than the control group. But you just kind of, what I'm hoping you take away from this is that kind of finer grain detail. So that wideband is clearly sensitive to these subtle shifts in middle ear mechanics that we can't identify with kind of standard tympanometry in the way that's grouped, or even a fusion volume. And that's supported in this case by the OAE data. And we hope eventually by the behavioral audiometric data. We just don't have quite as much of it, so it's harder to show on these. So a few key takeaways. Hopefully this work has demonstrated that wideband shows strong potential in differentiating the volume of a fusion, which can't be said for standard tympanometry. And we believe this is significant because that volume of a fusion also appears to be driving whether and how much conductive hearing loss is present. And having a tool that could predict kind of conductive hearing loss in this population would be considerably valuable given how challenging behavioral audiometry is in this population. And our kind of preliminary data also suggests that wideband might be able to directly predict that conductive hearing loss, which would provide an ear-specific, kind of non-invasive objective estimate of hearing that we don't have in any other capacity. And also kind of based on our longitudinal monitoring so far, it does appear that wideband is really sensitive to subtle shifts in middle ear mechanics that might also correlate with subtle shifts in hearing that we just can't identify using standard tympanometry. And so with that, I just want to thank you for your attention. And before I take questions, I just wanted to highlight, we have a really amazing T32 postdoc training program at Boys Town. So if you're interested in work like this, or really any work in humans, in hearing science, in language science, speech science, or in neuroscience, or kind of some combination of those, we have a lot of postdocs that are co-mentored by multiple people. Consider looking into our postdoc training program, whether you're a trainee or if you have a student who you think might be interested. There's a quick pre-application online that you can go on to see if there might be a good fit there. And my contact information is there, and yeah, super happy to take questions.
Hey, thank you, Gabby, for that excellent presentation. You said you're ready for questions now? So I have one question from the chat from Gabriel Alberts. He asked, what is a clear ear, and how is it different from a partial or normal ear?
That's a great question. So the clear ears were ears that at the time of tube placement, so again, the kids were all enrolled when they were identified an ENT as having fluid, but then sometimes it can take up to even, I think the highest was like 57 days till I have surgery. And so clear ears are ears that at the time of tube placement no longer have fluid, but we distinguish them from normal ears because they do have that very recent kind of history of OM. So we don't think it's necessarily normal ear, and there's probably some kind of residual inflammation present and things like that, but there's no measurable fluid present at the time of surgery.
Right, let's see, is anyone else have, questions? I don't see any other questions in the chat and nobody's raising their hand. Or if they are, they, I can't see it. If, anyone else wants to ask a question, they can unmute and ask. No. So that,
Oh,
okay,
so
Oh.
clear.
yeah, I've got another question. This is from Joshua Hyachek. Have you looked at higher frequency temps, such as 660 or 1000 hertz? It appears that those frequencies might be more sensitive based on your data.
Yeah, that's a good question. So we haven't, and certainly like, so 1000 hertz temps are very standard in clinic now for babies kind of between 6 and 9 months and younger. I haven't looked at it. We could kind of add that to the protocol to see if there is some sensitivity, but my gut is that like one problem with that is knowing like when to do which frequency temp and which frequency temp to trust. And I feel like wideband just sort of takes that variable out of the equation. So another example of this is individuals with Down syndrome. Their middle ear mechanics are often immature, kind of compared to an age-matched neurotypical person. And so sometimes we think that, you know, doing 1000 hertz temps on them, even when they're older than 9 months old, will be more informative. But then it's hard to know, like, at what point does the system mature and we should be doing 226, we should be doing 1000. So I think having kind of a wideband stimulus takes that variable out of the equation. And that's why I think it's probably advantageous versus using single frequency tympanometry. But I haven't directly looked at it in this. Oh, I just saw Tao has a question. Hi, Tao. That says, OMI often comes with negative middle ear pressure, which also affects sound conduction. And how is this considered in your study? And that's an excellent question that I somewhat intentionally didn't talk about because we are still trying to figure out how to really factor that into things. I do think it's a really important question. One way we've kind of looked at it is compared wideband at tympanometric peak pressure, where kind of any effect of negative pressure would be theoretically kind of removed because you're looking kind of matching the pressure on the ear canal side versus ambient absorbance measurements. And so kind of comparing those two things gives us some sight, I think, into the contribution of negative middle ear pressure, but it is a question that is very much on my mind, and we have still not completely figured out how to factor that in this population. So more to come. And if you have ideas, I'm all ears. I see a hand raised too, Steve.
Hi, I have a question, and so my question is, if you've ever looked at the population of children who may have a history of aminoglycoside therapy, such as like gentamicin, for example, because they suggested that gentamicin is what caused my hearing loss. So I was just, and I know that that's very common. So I was wondering if you've ever looked into that, the ototoxic pharmaceuticals as a cause.
Yeah, I haven't looked at a kind of correlation either between wideband and individuals who have ototoxic exposure or kind of any influence of that on otitis media. My understanding is that those hearing losses are primarily sensory neural in nature. And so I don't think we're getting as much about kind of cochlear mechanics from these types of measurements, and otitis media primarily occurs in the middle ear space. But I have a collaborator on some work separate from this, but kind of related, Peter Steiger at Creighton, who studies ototoxicity. And we're also now thinking about otitis media and Down syndrome in particular. But if there is any connection there, I suspect that in the combination of those projects, we might figure it out. So I will definitely keep that in mind.
It looks like we've come to the end of our allotted time. I don't see any other pending questions. I suppose if anyone else has questions, they could email you, Gabby, at the
Certainly.
email address on the screen. And
Of Or that's gone now, but I'm Googleable.
Okay, so that concludes the seminar then.
Awesome. Thank you all. Thanks, Steve.
Oh, Kathy.
Sorry, that was more of a congratulations rather than a rather than a hand up. But I think that was a really great seminar, so thank you so much.